So I want to just start by acknowledging, of course, Dr. Duncan Sinclair, who this lectureship's named in recognition of, for his incredible contributions to the Faculty of Health Sciences and Medicine and to Queen's overall. And during his career, of course, he's held so many different senior leadership roles at the university, so many areas of expertise, and these include, of course, being the Dean of the Medical School and Health Sciences. Like David, I was reflecting in my contacts with Duncan over the years, and I remembered that in 1977, I was a life sciences student here at Queen's, and Duncan was teaching with Ivan Beck GI physiology, and little did any of us know that I'd go on to be a clinician scientist in gastroenterology. And in 1992, I was back at Queen's, and I was fortunate enough to receive my first CHR grant, and had Duncan as my first dean, congratulating me and supporting me in that role. And then most recently, within the last couple of months, Duncan was gracious enough to have lunch with me and give me some sage advice in my role as the interim dean. So Duncan, thank you very, very much. When you have so many different roles and different areas of expertise, of course, I guess occasionally this can lead to confusion. And I learned yesterday at talking to one of my family medicine colleagues at Convocation that she had an interesting experience many years ago with a persistent patient who insisted on seeing a specialist and demanded that it had to be the dean. She said, well, yes, I'd be happy to arrange that for you, and I'm sure that Dr. Sinclair would be pleased to see you, but of course you do know that he's a vet. But the truth is that Duncan's had a huge impact on many Queen's graduates and faculty, and of course advancing health policy across the nation, and because of that having a huge impact on our well-being. I also learned that this lectureship was established in 1997 by then the president of the Medical Research Council, Dr. Henry Friesen. And some of you may know that he sadly passed away this past year. Like Duncan, Dr. Friesen's contributions in the field of medical research and health policy are really an understatement, just huge contributions. And I was reminded that he actually was responsible for creating the Canadian Institutes of Health Research, and was really a driving force in the research environment that we all enjoy today. So I want to acknowledge both of these iconic people, Dr. Sinclair and Dr. Friesen, today, and just how fortunate we are to have them as scholars that are connected to health policy here at Queen's. This lecture, of course, is about the future, about artificial intelligence, and as I mentioned, I really found the talks that we've had so far incredibly inspiring and thought-provoking. And I want to thank Catherine and her team for organizing this tremendous event. And so on that background, we look forward to having this keynote address to cap off this terrific day. And so I'll just call on Dr. Mabey to come forward and introduce our guest speaker, Dr. Rosella. Thank you.
Change of plans, it's me again. Sorry. I've had a lovely opportunity to work with Laura in the past, and it is really my great honor to and privilege to introduce Dr. Laura Rosella today, who's our 2025 Sinclair Lecturer. And really, the warm-up for the day is just the perfect opportunity to hear from Dr. Rosella, who is an extremely impressive researcher. She is a distinguished Canadian epidemiologist, a public health scholar renowned for her pioneering work in population health analytics, chronic disease prevention and the integration of AI into public health systems. Dr. Rosella holds many hats, a testament to the wide range and impact of her work. She has over 250, I think it might be 300 publications, which for all those researchers in the room know how extraordinarily difficult that would be. An impressive 13,000 citations. Dr. Rosella is a full professor at the Dalla Lana School of Public Health at the University of Toronto, where she holds the Canada Research Chair in Population Health Analytics. She also serves as a scientific director of the Population Health Analytics Lab. Take a look at her website, it's fabulous, focusing on predictive modeling and data-driven strategies to improve health outcomes. She is also the Stephen Family Research Chair in Community Health at the Institute for Better Health at Trillium Health Partners, and the site director for ICS at the University of Toronto, and also a faculty affiliate at both the Vector Institute and the Schwartz-Reisman Institute. She, on top of all those hats, I know it's hard to imagine, she has received numerous awards and recognitions for her work. I was most impressed that she received she was named Canada's top 40 under 40, which is very impressive. And I'm not even finished, but I will just end on this. I always like to prepare and read up on the speakers and all of the impressive works they do, and I've known Laura in her work looking at AI in public health and a CHR grant. She has 7 years for training. And I read a 2018 article, and I thought this was very interesting. Up next for Dr. Rosella lies on the new frontier of artificial intelligence. So here we are, 7 years later. It was a new frontier, and I think we're still in it. So Laura, welcome. Thank you.
My goodness, thank you so much for that very kind introduction. It's such a pleasure to be here. Especially an honor to be here on a lectureship named after Dr. Duncan Sinclair, who is very widely respected and very well known, and we cite often at the School of Public Health in Toronto, so such an honor. And it's been an amazing day so far. I think you're going to hear some things that reinforce what we heard, maybe some things that provoke, and I'm really looking forward to the discussion today. So the title of my talk has this tipping point idea in it. So what is a tipping point? A tipping point's this critical moment that once we pass it, we have a system that we do not recognize in the same way. Everything's different, the way we function, the way we work. And I believe we are just ahead of that tipping point for health, for AI and health. And I actually disagree with some of the futurists that we're going down a hill after. I think it's going to go up in a very rapid way. What I'm worried about, and what I think everyone in this room should be worried about, and why we all need to engage in this space, is that once we've passed that tipping point, it'll be very hard to put the genie back in the bottle. And so now is the point at which we define what AI for health means, and it means engaging. Everybody needs to engage, especially those that are deeply embedded in health systems. Not necessarily, that does not mean you need to have a background in AI to engage, and I'll talk a little bit more about that. So this is what I'm going to cover. I'm going to talk about why the tipping point matters right now, and then we'll go through how we build AI for health. Specifically, the word health is there, not healthcare, not public health. It's both. I'll talk a little bit about the paradox of progress, and we've heard a little bit about some of the scary things that can happen, and hopefully I'll try and reassure some of you that I think we're on a really good path to get through that, and then finally how we get there. And this is largely about deployment and how we make this work for our health systems. So we've had 3 industrial revolutions, in case you didn't know. And many believe that the 4th industrial revolution is all about AI. This is what the tipping point's about. We went from hand production to machine production. We had the technological revolution with electricity, the internet, remember before the internet times? So we're approaching the 4th one. And there's lots of good reasons to think AI is going to define it. Global spending on AI is about to reach over $300 billion. We now have AI technology that's exceeding human tasks on several things. I'll show you that in a moment. We have over 150 zettabytes of data every day. So this is like a trillion versions of these hanging around, and it's growing exponentially. And over 80% of healthcare organizations are engaging, and probably many health organizations that many people in this room are interacting with some kind of AI. They're starting to measure the ROI, like we heard from Dr. Barber, 4 hours a week being saved. This graph always surprises me, and it's out of date now, but I think still worth looking at it. So what's really happened, especially since we think about ImageNet breakthrough in 2012, and I'll say the 2010s, AI is getting faster so quickly. So these are various human tasks. There's a great series in Time magazine on this. Handwriting recognition used to take so long for AI to do. Even those images we saw up earlier, even the imperfect ones, it's not working well. Well, I can guarantee you by the end of this calendar year, AI is going to be able to decipher those images. And when you take all these tasks, including many medical exams and all these other tasks that humans do, AI is surpassing them pretty much within the year that they start training on these. And a month ago, I was in Zurich, and we got a group together to test all these auto ML tools on health data analysis. So these are tools that help us do, so for example, there's a tool called Elicit that does systematic reviews in 5 minutes. If you've done, probably every medical student in here has done a systematic review, and many have done, many other researchers have, 5 minutes. So just let that sink in for a moment, including all the data extraction. We tested a bunch of auto ML tools, including one that is fascinating in terms of its methodology. It's called TabFN. It was just published in Nature. You have an Excel sheet, and you press a button, and it develops and validates prediction models. Full validations. Actually, some better validations than what we usually do when we do this manually. So this is pretty much changing all aspects of our life. There are some things that don't work well with these tools, especially around reasoning. I think AI is not there yet, but it's happening very fast. And most experts believe by this model says 2033, I think it's more like 2040, we'll have transformational AI. It'll totally transform our everyday life. So even just thinking in 5 years. So I was thinking about this in preparing for this talk. What couldn't AI do, at the start of the pandemic, but can do today? So we are already seeing all of these examples of large language models synthesizing complex medical histories. Patients are using them, clinicians are using them. We saw these great examples with CT, MRI, and radiology, and we're not just looking at X-rays or CT scans anymore. We're taking data, all types of data, and putting it into these models with the multimodal AI. Real-time conversations. So my colleague that works for a big health system in the US, when you call, automatically speaks to you he said at the time, 56 languages. So talk about patient-oriented care. Whatever language you have to pick up the phone and call, you have that immediately in real time. You're getting that language back. And that's something that's, again, these tools were not very good if you tried to use them a few years ago. They're very good now. And we have near 100% languages. We have lots of examples being used in health systems, drug discovery. The advances in drug discovery are significant. The time it takes to make a drug discovery has probably been reduced by 5 or 10 years on average because of AI. Really interesting, the first autonomous AI was FDA cleared last year, eye health for digital diabetic retinopathy screening using handheld cameras. So lots of stuff is happening. And again, it's happening whether we like it or not. I think you'll see that I have some optimism for what it can do for our health systems, but there's this urgency right now, right now, in like the next 365 days, to shape this and not just adopt it. So our health systems are in trouble. in case you haven't noticed. And many of you work in these systems, and they're in trouble. And the question is, if we're going to take this opportunity for a transformational change like AI to just keep doing what we're doing, or actually start thinking about how we use this moment to redefine our health systems. Earlier, end of last year, we did a report with the Ontario Health Association, and we modeled the projected burden of illness in Ontario. And this is just one of the terrifying graphs from that analysis. This is the most comprehensive picture of what health system burden will look like in our province that's had been done to date, and we're building off similar work that had happened in the UK. And basically, the number of individuals with major illness that are going to need hospital care, mostly, this is major illness, in Ontario by 2040 is equivalent to the whole population of Kingston and Ottawa combined. So it's like, imagine our health system now at its brink, and in less than 2 decades, the whole population of Kingston and Ottawa is showing up at the door. So this is why I wanted to just put that in your mind, that as we talk about AI and all the exciting things we can do and how it might save a few minutes and all of that, we have to be more ambitious than that. Are we going to use AI to just optimize and do things a little better in a system that's not working? Or can we use it to reimagine? So that's my question for you all. You can let me know what you think about it, but I think our ambitions have to be no less than that if we're going to take this moment, this tipping point, and actually change population health and health systems. So let's talk about what AI means for better health. So this is, I was thinking about this the other day, probably like my oldest slide. I use this slide, I've been using this slide probably for about 15 years because I'm a person, I'm trained in public health. I work in health systems. You'll note in my introduction, I'm in a school of public health, but I'm embedded in one of Canada's largest health systems, $1.7 million visits a year at Trillium Health Partners, in one of a massively growing population. We're building Canada's largest hospital at the moment. Massive system. And the reason why I'm there is because of this idea that, of course, we need a well-functioning health system where we have good patient outcomes, good high quality of care when people need it. And it needs to be sustainable, to our earlier modeling work. But we have to go upstream. We have to think about those patients before they get to the hospital, and we have to think what happens when they leave the hospital. And there is an opportunity to deliver high quality care for individuals and patients and think about communities at the same time. And there's some really interesting opportunities with AI to do that. So that's what AI for health means. It means improving population health. So if we're successful, we have fewer people developing diseases that are preventable. We are promoting health in our environments, in our communities. We're reducing health inequities. And then when you do need medical care, you're getting earlier and more accurate diagnoses. It's personalized and optimized in a better way because of the data and tools we have. And hopefully we are being more efficient because we need, and we're increasing access. And I'll show you some examples of how that's happening. But it can be very easy to lose sight of these goals when you're in the AI world. And I say this as someone that loves data, that loves developing tools, that really is mesmerized by what these tools can do. If they're not doing these things, it does not matter. And we have to start benchmarking these tools against these things. And we're starting to get there, but I will say I've been in the space for about 8 years. Pretty much for the first 5 years, we weren't. It was all about performance. It was all about high-performing algorithms. Cool. They weren't doing we weren't even measuring what they did on the outcomes that are most important for a reimagined health system. So what's happening now? We have, these are CPT codes, so reimbursement codes that are used. This is in the US. We don't have reimbursement codes for AI in Canada. It's one of the reasons they're coming in different shapes or forms, but it's one of the incentive structure systems that are probably limiting our ability to adopt these technologies. But where's AI being taken up? It's one good way. This is one of the biggest analyses of CPT codes in the US. So it's almost exclusively diagnostics, which is not unexpected. Heart disease, diabetes, liver, and then we see some other radiology applications. So again, not surprisingly, developers picked the most common chronic conditions and focused on diagnoses, and those are the technologies we had first. Again, asking ourselves, definitely this can help with accurate diagnoses perhaps, but thinking about all those goals of health, it's not clear how we're gonna move the needle just focusing on these. But this is where the action's happening now. The good news is we're starting to see a lot more AI evaluations in healthcare. And so, we even have journals dedicated to AI. We have New England AI, we have JAMA AI, we have lots of different types of evaluation. I'm going to talk about evidence quite a bit, which is a good thing. And it's very interesting when you look at what they're telling us. And you really have to think about it in the goals of health that I mentioned to actually see whether this is impressive or not. So the first one's an evaluation. I'll note it's an RCT. So we're seeing a lot more RCTs of AI technology in healthcare. And this is a stress echo test. And their conclusion, very interesting, an AI augmented decision-making did not meet the non-inferiority endpoint. So it's not that it was better than the humans. So again, like if you're just superficially seeing this, just yay, one for the clinicians and AI loses, or whatever side of the battle you're on, because it seems like there's always a battle. But think about this for a moment. But they were equivalent. Equivalent is a big deal, because if you go to a rural area where there is not access to this types of specialized physician to do these types of diagnostics, you've all of a sudden created an access point. And so that's thinking about it from a system point of view versus just the isolated AI versus physician. This other one, also very interesting, where they were using machine learning for public health screening for Hep C carriers. And again, they found, well, we didn't identify more cases. It was the same, so important that it wasn't worse. But we did it with 100-fold greater efficiency. That's huge in a system that's completely strained. So again, thinking about these evaluations that are coming out now and how they actually play into all of these outcomes I mentioned earlier. Another example of a new capability that's coming out, GPT translation on discharge summary notes. So we have a study here where they measured comprehension of the patient and how this type of technology, large language models, significantly increase patient comprehension. And again, there's time savings, there's better patient outcomes, and these are the types of evaluations we need to think through how we're putting this in our system. In some of our work, I work with a lot of large linked population health data that many people work with. And I often get the question, like, why do we need AI? It's just structured data, it's billing codes, it's geography, it's drug claims, it's data we've worked with for a long time. So what we found actually, that these machine learning methods, even though it's structured data, actually significantly allow us to use that data much better. So these data are complex, not necessarily in their structure, but in time. Patients have lots of time-varying information in the way that we link different data together. And when we build prediction models with this data using machine learning, we are seeing performance gains. And to what Dr. Morrison was saying earlier about using some of this for health system planning, we can do this to predict avoidable emergency visits. We used it during COVID. We used it for chronic diseases, premature mortality. All of this can be done with fairness and subgroup assessment. So I'm going to come back to this later about this bias concern. We are miles ahead of where we were in terms of what we do to detect these biases and to address them. And you can do that with these types of data. And in some of these models that we work on predicting, we can now bring in environmental data. You can use a convolutional neural network on an environmental image just like you can on a lung CT. And we can now start bringing in all the social, ecological determinants of health in ways we just could not before. So it's really opening up our ability to do this type of work at a population level. So what are our opportunities? Before I talk about what they are for AI in health, let's just recap what's new and what's not new. And we heard a bit of this. So what's new? The methods, not as much, although there's been some transformational advances in LLMs, but the biggest thing is the data. We have data now we just did not have, and we now have computing power we did not have. So that's been the biggest transformational change for AI. Our algorithms are getting so sophisticated, we're moving beyond simple prediction or simple pattern recognition to very complex pattern recognition, which is allowing us to use new data sources we couldn't before. We're slowly figuring out how to integrate this into practice. I'm sure KGH has several, well, we heard several AI models running. At Trillium, we have several AI models working in practice. It took a while to get them up and running, and I'll talk about that. And then we can scale this across Canada, the world. It's unbelievable. So that's the new things. But I just want to mention what's not new. Because if we lose this, this is what I'm worried about us losing as we go over the tipping point. What we're trying to achieve in our health systems hasn't changed. And we have to constantly anchor on that. Preventing disease, earlier detection, all the things I mentioned before. The importance of humans hasn't changed. Actually, they're more important. And I'll talk about that in lots of details towards the end. But trust is very hard for AI to build trust without humans. Human judgment, all of that, actually, the role is being elevated. And I'll talk about that a bit more. We've heard a lot about ethical and equity concerns. So that hasn't changed, and they're amplified because now we're scaling this 10x, and the requirement for high quality evidence and standards. We cannot forget that all applications in health need the same standards that other public health or medical interventions need. So that means high quality evaluations, RCTs, prospective evaluations, real world studies, and was mentioned earlier, this concept of continuous monitoring. We have to remember this. It's very easy to get very excited about a high performance of a model, but unless we have those evaluations, like the ones I just showed you before, we can't start implementing this in practice at scale. And that's where the shift is happening in AI and health right now. So those are our opportunities, focusing on health, being human-centered, ethics and equity, and the evidence and oversight piece. And I'll just, before I start talking about the paradox of progress, say that some of you may have heard this term, human-centered AI. It's a very useful framework to think about what we actually need to start doing right now, which is making these tools user-friendly, augmenting human capabilities, not replacing, ethical. Hopefully these tools are being used to improve human life and our impact on society. I know it sounds obvious, but again, if that is not the goal of the person developing or the groups developing the tools, that will not happen in safety and reliability. So I work with a lot of human-centered AI experts, and I'm sure there are some great ones here at Queen's. They're essential to any team trying to either develop or deploy AI in such a complex human system of healthcare. There's almost no more complex system in the world. So let's talk about the paradox of progress, which we've been hearing a lot today. Like, everyone, we're excited and now we're terrified, and we're excited and now we're terrified. And that's about right. Innovation accelerates risk. It's true, almost always. Any type of innovation that we come up against will have some kind of risks all of a sudden being accelerated that we didn't know about before. And the key thing here is basically managing these and making sure that we're thinking about not zero risks, but how we manage and mitigate these risks. And there is a risk, as was said earlier, to actually waiting too long, because some of these technologies are life-saving. They will get medical care into places that could not have it before. They will diagnose and improve patient outcomes. They can help reduce health equities and address access issues if used appropriately. And if we just wait, we'll miss those opportunities. And moreover, someone else will define them for us. How many, trying to ban any of these technologies, we did not adopt a scribe strategy in Ontario. Almost every physician I know is starting to use them. So it's going to happen. So it's our responsibility to say, we know it's happening. How can we define it for ourselves? This was also a really nice review that was recently done. And you can see, here's what progress we've made. And again, not surprisingly, if you saw those CPT codes, we've made all these diagnostic progress. We have some neat opportunities, but where are the challenges? They're all implementation, accountability, fairness. So in this era of the tipping point, we have to make sure we're focusing on those things. And the good news is almost everybody that has a background in health or works in healthcare or public health has value to add here, actually more so than ever. So I'm going to do a little quiz. I like science fiction, so who knows who these guys are? Who's that? Yeah, go ahead. Oh, you even know it's Hugh. Yeah, so what species is Hugh part of? The Borg, right? So the Borg assimilates in the name of efficiency and progress, and they're pretty scary. Okay, what about that one? Yeah? Terminator. Do you remember the name? Skynet. How about this one? You know it, yep. That's the Kalon. So this is probably a lesser known show, but I highly recommend, called The Orville. So why am I showing you these characters? So these characters, I actually think science fiction gives us an amazing opportunity to think through risks in a very interesting way. And in fact, if you really want to think through these things, inviting science fiction writers into the fold is a very interesting way to think about what happens. But these particular ones, obviously these are very extreme, but what can we learn from them? Because I think we can learn a lot about this progress, this paradox of progress. So first, the idea of controlled growth. Now in healthcare, we're going really slow right now with AI. So that's probably actually not the worst thing. We're probably moving too slow, but the idea of controlled growth. If you take something like social media, that was a really good example of uncontrolled growth where we went over the tipping point and did not think that through and wish we could take a lot of things back because it's actually causing a lot of harm in different populations. So the concept of oversight and monitoring, again, was mentioned before. I'm going to talk about this a lot. This is critical. The idea that as we roll these technologies out, that building very robust oversight and monitoring systems before they get too far. That happened with Skynet for sure. Security audits also, the idea of Skynet. So who knows that last year Canada built, or in name, built something called the AI Safety Institute. So you definitely know that. So we built, how many AI institutes do we have? Like 20? Around, they're popping up in every university. We only have It took us this long to build one AI safety institute. So think about it as the counterbalance. Literally people thinking, researching, and planning for the safety of AI, including existential threats. We won't go there, but all aspects of safety. So you need those counterbalances in the system. You need critical AI scholars who are being critical of what we're doing. That's how we build the balance into the system. Intentional redundancy. So if we become so dependent on some of these tools, which is something I know we worry a lot about in medicine, well, what happens if the tool goes offline? How do we build intentional redundancy into the system? Not focusing solely on efficiency. So the KLON were built to serve humans, to do all the things we didn't want to do. Fold the laundry, clean up after dinner. They did end up turning on humans because they found them to be irrational and a nuisance, and actually were starting to react to the way they were being treated. So again, if we focus solely on efficiency, I really worry about this. When we're thinking only about, well, how can I just make my day a little easier, which I want too. I want my day to be easier. I want everyone in the health system to have an easier day. But again, it's about those goals, those goals of improving outcome, because focusing solely on efficiency, we have lots of tales how that doesn't work. Making sure we're protecting autonomy and variation, that's a very good lesson from the Borg, and making sure we're building in human values into that technology. And that can seem like a very obscure idea. How do I build in human values into my AI algorithm? But this is exactly what human-centered AI folks do. Think about exactly how we do that. It doesn't necessarily have to be in the technology. It can be in the rules of engagement of how we use the technology. And finally, we need to just take certain things off the table. For example, in Europe, AI is banned for facial recognition purposes because the risks are too high against the bias of where we are in the technology today. Maybe they'll revisit it. Autonomous weapons seems like it's a pretty good idea. Let's take that off the table for a while. And the AI for Data Act that Dr. Flood mentioned earlier, that was kind of the spirit of it. Like, let's take the egregious stuff off the table so we can focus on some of the things that are not as risky. And if you're in a health organization and you're thinking about implementing AI, it's exactly the way to think about it. Like, maybe we don't start with predicting a high mortality condition as a starting point, as the first AI algorithm we're going to implement in like a life or death decision that's actually even hard for experienced physicians to make. Maybe that's not the starting point. Maybe we should start with some lower risk tasks, and I'll talk about that in a moment. So this paradox is all about getting that balance right. And our ability to succeed in getting ahead of this tipping point so that AI is defined for what we need is going to be this. It's our most important tasks. We're not so risk averse that we're not benefiting, and then worse, someone else is defining it for us and we have no choice but to adopt something we don't want. Enter electronic health records. That's exactly what happened. Or we actually think about this and divine it and have a say in how it needs. And so that's why it's job number one at this moment in time. And so we've heard about the ways to do this. So how do we do this? I don't want to just come here and say, like, we must do this and it's not happening, because actually it's happening. And I want people to feel reassured that we've made incredible progress on these things. So first of all, there's two sides to it. Actually, I'll show you my, public health, we love the Swiss cheese model. Remember the layers of protection in COVID? It's the same thing with AI and health and risks. Like when I showed you the KLON and the Borg, there is not one line of defense here. And they all serve different functions. Regulation serves a very important specific function. It's not enough, but it serves one. And the other ones are guidelines, standards, best practices. Now we are starting to see guidelines written by the FDA, by different medical specialties. Public health is developing one. Standards. So now when I submit a machine learning model to a journal, there's actually standards of how I validate that model that didn't exist before. The requirement for an equity assessment, subgroup assessment, external validation, they didn't exist before when we started. But now all of these standards are coming online. That's really going to help, and we need all of them actually functioning to work. And we need them adopted, of course, like clinical guidelines. The other piece is the engagement, and this is kind of my message to you, is to get engaged. Some of you are heavily engaged because you're interested, you're working in this space. Some of you are in the health system wondering, like, do I have to learn how to code? No, the answer is no, you don't have to, but you have to get in there and say, I think actually that's going to be a problem because this is the workflow. Or talking to patients. And so in one of our AI deployment projects, we talk to community, and we almost exclusively talk about trust and transparency. And again, if we know that early on, we can build our tools in a much different way. So these activities need to be happening, and layered together, they'll have an impact. But let's talk about a few of them. Algorithmic bias has come up a ton already. We know it's a problem. Actually, we've known since the beginning, and we had, of course, the 2019 Ziad Obermeyer paper showing very clearly how these algorithms can be biased and make decisions that reinforce biases. What I want to emphasize is that we got to just take it a step further. It's not just the models. Actually, because of those standards and best practices, we're getting a lot better at models, at least detecting when there potentially could be bias and assessing it. And AI fairness is a whole field. Computer scientists spend lots of time thinking about this now. Again, it was not so prevalent in 2016 or 2017. Data is still a huge problem, though, because a lot of the data are biased. We don't have infrastructure to maintain it at the quality that we have. So that's a critical piece. But even if those things are working, how the model is being used, who has access to it. So here's another thing I'm very worried about. There's a lot of AI technology out there now that will take your wearables, you can get your own blood test now, and using AI give you insights that will improve your health. Who's accessing that technology? Who's it available to? It's definitely not available to most individuals. It's available to those that know about it, have ability to pay. So there's lots of policy things in place that actually could dramatically increase biases in health if we don't think about that in advance. This is a really just nice review for people that want to read about this more. You have to think about bias from the problem that you think about in the beginning all the way through to post-deployment. And so that's going to be, again, our next frontier, not just thinking about the models, but actually everything around the models. The other thing is the black box piece, which came up a little bit, but not as much so far. So number one concern people have is, I have no idea, it's too black box, we don't know exactly what's happening. And therefore I can't use it. So what they're really saying is, I don't trust it. And the way you build trust is not necessarily going to a more simple approach. In fact, I see lots of people misinterpret simple linear models all the time. And it's just not their training. They didn't see it. They don't, remember their biostats course. Like it's not a good or a bad thing. But if we're saying that, in order to use multi-layer deep learning models, it can't be a black box, well, we're kind of missing the point. Really, it's about interpretability, explainability, and transparency. So interpretability, someone should be able to understand how model parameters are using the model. And there's some amazing visual methods coming out in computer science right now to do this for very complex models. So visual analytics are going to be the way that this becomes very usable for everybody. How decisions are being made, and most importantly, transparency in how it was created or validated. When we did a workshop with public health practitioners to say, tell me what AI tools would be the most valuable to you, and we brought AI developers there to listen. And the one thing they said is, I don't want to have to be the one, this came up earlier, to say, oh yeah, that's the right AI tool. Can there just be like a green check mark that I know that this tool's been validated or vetted, and then I'll feel comfortable using it? And so that idea of creating the big check mark, we have to do this. We all use technology we don't understand, that we don't see. I have no idea how this thing works. I have no idea how lots of things I use every day works, but I trust it. And so building that trust in the system, and this is what Dr. Flood was talking about, is going to be essential. And then also just to, again, end on a little more of a positive on this risk management, these guidelines are coming out. So earlier this year, the Future AI Consortium, which is an international consensus guideline for trustworthy and deployable AI in healthcare, 117 experts, 15 countries, lots of Delphi, all the methods, have come up with very detailed recommendations to how to do this. So we can no longer use the excuse that it's too risky. I don't know what to do. We know what to do. We have to get on to actually doing it and building the systems that can do it. And you can agree on maybe 29 should be this or that, sure. But at the end of the day, we know what we have to do. Fair, universal, traceable, usable, robust, explainable. They mostly fall into there. Now we got to build the systems that can actually do it. That's our opportunity. And Dr. Flood already talked about liability. I'll just add one point on this to say, in the US, again, that idea of physician in the loop, the Biden administration came down on physicians, you are liable if you use an AI tool. And there's a debate going on right now, and that's probably going to be changed. But right now, that's where we're at. We don't have the answers to these questions at the moment, which we need to be able to scale this. Okay, so let me just end us off on how we actually get there. So we talked about why the tipping point matters now, and hopefully I've convinced you that it's not just an opportunity to integrate a new technology, but actually change our health system. And we know why it hasn't happened yet and all the risks, but what can we actually do? And so here I want to focus a little bit on the deployment side. And again, like the Swiss cheese, everybody has to be involved. In our hospital, as we're rolling out our AI strategy, we are thinking about individuals who work on the front line, we're thinking about the organization, and we're thinking about society, and this is largely on the regulatory space. And so the requirements are that high quality evidence, and I'm going to talk about that in a bit more detail because it's so essential, all the change management and integration with workflows that was mentioned earlier. I'll also go talk about that in a little more detail. This oversight and capacity building. So every single individual in the organization should feel comfortable and aware, and including patients, families, and caregivers on how AI is being used. It should not be a secret locked in a box that you need a PhD in computer science to understand. Everyone has to know. And so it's our responsibility, that's how we're seeing it, to get everyone on board, aware, comfortable, and then there'll be obviously super experts in the mix. So we're moving, right? We're moving from this AI versus human comparison, from using one data set at a time, from lots of annotations that are very manual, and we're moving to this real world data coming from lots of sources, very little manual transcription of the data, and we're focusing on deployment and that human AI collaboration. That's what we're building towards. So this is the life cycle of responsible deployment of AI in healthcare, and it's also the same in a public health setting. And I'm going to focus on 1, 6, 7, 8. So the idea that we decide what problem we're working on, do all the model stuff, which has been the focus of the first 10,000 papers in AI in medicine that were published, including some of my papers, so it's not a criticism. And regulatory, I think we've covered quite a bit, but I'm going to talk about these ones. These are the messiest ones, the ones we're not doing in a systematic way, and the ones that are actually going to unlock the future for us in AI in medicine. So let's talk about the first one, which is the problem identification. We're very poor at this. We are very ad hoc. We take We aren't taking a principled approach of how we think about which AI technology do we want to implement. It's mostly opportunistic, which again, not necessarily a criticism, that's just where we're at. What AI technology do we have? Let's implement this one. No real analysis on who does this affect and what risk. And so really thinking about, do we really need this? Not just, I mean, I won't get into, because it's a whole other topic, the environmental impacts of AI and all the other things around it, but we can't just do it because it's cool and fun. I'm not suggesting that we're doing that, but some of these things, again, how is this improving patient outcomes? Is this reducing health equity? Are we being more efficient with this? I think some of those questions aren't necessarily being asked right at the beginning. And is it feasible? Even if it's an amazing technology, if we are not ready as a system to implement it, and there's lots of reasons why we may not be ready that are just realities, maybe not. And then the risk piece. Again, is this a very high risk solution that's going to make life or death decisions on the patient? Or is this going to help with our flow in the ER a bit more? You know, we have to think about that. And then the last one is one that's very dear and near to my heart, which is it's sustainable. And I don't necessarily mean sustainable in terms of costs, but can this be put in a system? Let's say you have someone in your hospital that's developed an amazing solution. What if they're gone? Can anyone use it? What if it starts going wrong? Does someone know how to fix it? Do I have to email the first author of the paper? That's not going to work. So it's actually building the system to make it work. So, I mean, this is just a very simple risk matrix to say, you kind of want to start with the highly feasible and something that's actually a priority for your strategy in your hospital or in your health system or in your public health system. And think that through in a very principled way. And setting that up through governance or other ways is one way to do it. This is just an example of, risk. You can use risk assessment matrix to do these, but I think most people could actually do this very simply with some criteria. So let's jump to, we've developed the models, they're working great, there's some regulation in place. Really thinking about what information is given from that model, usability, alert fatigue, compliance, hospital resources, and most importantly, standard operating procedures and clinical workflows or public health workflows, if it's in a public health setting, what do I do with this information? Once I have this, what are the next few steps? And again, that's not necessarily the role of the developer of the technology, that is the role of people that work in the system, people that think about implementation scientists, science, principles, those types of things. So you put it in, and then you have to actually think about what it means to turn on this model. So gold standard approach would be this silent deployment. You turn on the model, and you don't tell anyone you're turning it on, aside from a few people that are looking at the data. And you see if the model's doing what it's supposed to do. And many times it's not. And it's not because something's wrong with the model. Maybe something went off with the data. There was a label in there that wasn't exactly what you thought it was. And this has been our experience turning on models in the hospital. So if you don't do this phase of silent deployment, it can go way off. And we get it back very quickly, but this concept of silent deployment, and you might even do some real-time assessments from a human perspective as opposed to what's happening. You update your model. I mean, if you can make it better, why wouldn't you? The more data, the model improves. This is the challenges with regulation that Dr. Flood was talking about. And the other final piece would be the rigorous evaluation. If you can do it in a randomized study or a very rigorous prospective study, and you can show that the outcomes, patient outcomes, efficiency outcomes, have improved based on that in a very rigorous way with the control, then you can start thinking about scaling. And again, we see about 1 or 2 prospective evaluations a month now with AI. 5 years ago, 0. One of the first prospective evaluations of a clinical risk model was in about 2019, sepsis model, multi-site. So we've just got on the bandwagon of actually generating the evidence we need to deploy these. And that's where there needs to be a lot more attention. But good news is it's actually happening. And then the model's running. Great. You need a post-deployment and monitoring infrastructure, ideally in your organization. And yes, that means these people need to be on call 24/7 if it's being used 24/7. Because if it goes off in the middle of the night and it's not working, you're not going to call the primary healthcare providers to fix it. That's not their job. You have to actually have the team responsible, and that's where some of the future visions of a hospital using AI is going to be. There are going to be data science teams on call 24/7 doing this monitoring, checking to make sure performance is not degrading, and updating as needed. These are real and living technologies in the real world. So don't even think about implementing multiple models in a healthcare system if you haven't thought about how you're going to resource and set this team up, is my advice. Because it's going to go down, and either you're not going to know, or you're going to know and not be able to respond to it. So that's where we're at. Evidence in rigor in the study design, the methodology, transparency, reproducibility, that real-world validation, all of the regulatory things, and all of that post-deployment monitoring. I was talking to a group of very young, like computer scientists and software engineers, and they said to me, like, everyone jokes with me that my job's going to be replaced because AI is going to do all my coding because they're mostly technical folks. And that's what I said. I said, focus on the post-deployment environment, how you monitor in real time, how your expertise can be used for that part. I promise you'll never be out of a job. At least, you know, it'll take hundreds of years for us to be able to automate that type of work. And one last thing I just want to say, I'm sure there's some surgeons in the room here. I always found it very interesting that in the evolution of robotic surgery, we didn't go technology first, really. From the beginning, it was about is patient recovery time improving, have we reduced complications, and nothing would happen without those preclinical and then randomized controlled trials. Nothing. It was baked in from the beginning. And it was slow, for sure, and I'm sure there's lots of advances now, but with AI, somehow we missed that. We went right to technological performance without thinking of those outcomes right from the beginning, and the basis of medicine and using evidence. So I think we have an example in our own field to show that we can put that evidence first and make progress. So the deployments that exist right now, and I just have a couple more slides. What have we learned from them? And again, it's early days, although some hospitals in the US have about 60 AI algorithms running. That's probably the most I've seen. We have about 10. I don't know how many are running in your hospitals, but we are starting to learn from these early deployments. So the first one, no surprise, it's complicated, but I think there are things that we can put in place. The one big question mark, again, if you're interested in the space, I don't know how to handle multiple models yet. I don't think we've thought that through. We keep thinking them through one clinical workflow at a time. What happens when they tell you to do different things? They conflict with each other. We're going to get to that point really soon, so that needs to be thought of. We've talked a lot about data quality, but I want to be clear that when we talk about data quality, we often talk about how the algorithms were trained. Well, they were only trained on this many and this type of population. It also is the data quality that they're being applied to. That's where we see a lot of the models go off and do weird things in the real world. Has to be data quality on the inputs and when they're being applied. The evidence I've talked a lot about, and the trust. And what I just want to say about trust is that trust has to be earned. And once it's broken, it's very hard to get back. So thinking about this responsible deployment as our most important job to get over the AI tipping point. And I'll just say, you know, this is the puzzle pieces, and this is where it gets hard and where people really struggle about how do we actually make this work. And it's about trying to do all these things at the same time, building the workforce capacity, which is why I do so much work in capacity building. That independent oversight, making sure it's adding value to the workforce, making sure we have a modernized deployment infrastructure. It can seem like a lot, but if you set up your strategy with these goals in mind from the beginning, it'll make things go a lot faster. And we've, again, come leaps and bounds on a lot of these. This is our deployment team, but I talked about that later. So I'll just end with a couple of final thoughts about where we're going to be as we cross the fourth industrial revolution. I really believe we will have multimodal data that's processed in real time. We're going to have scale, and it's going to be widely adopted. And to be honest, 5 years ago, I thought we were 20 years away. So I don't like making predictions on when that's going to happen, but it's happening, and it's going to happen soon. What I would like to see is that all of that technology is being used to improve health outcomes, and none of that is possible. And I did not see Dr. Flood's talk, but I'm saying the same thing. If we don't get the governance and the monitoring and the transparency set, none of this is going to be possible. So it's where we have to focus our attention and make sure we're not seeing it as a barrier, but designing it in a way that works for us. That's what's going to make this possible. And the good news is humans are the key to getting there. We have to be at the center, highly involved, talking about this augmentation, which I think is already what people are talking about now. Again, wasn't the case. We heard a lot of replacement. It's augmentation, focusing on trust, and focus on building a healthier system. So I'll just end with the question again, because I think it's our most important job, is to make sure our health system can do what it was designed to do, to keep our population healthy. And this is a moment. It's not to say AI is going to solve it, but it's our moment to say, when you have transformational technology, are we going to reimagine our system for what works for us? Thank you.
So thank you so much. That was a fantastic talk. I learned a lot. As I said at the beginning of this whole session, I don't know a lot about healthcare and AI. I know a lot about how much energy AI requires. And I think an awful lot about how many new power plants and how many new facilities we're going to need in order to drive all these engines. But it's really nice to sit on the other side and to learn a little bit about what is happening. And I know that there's going to be a lot of questions around the room. So we're going to open it up for some conversation. And I think somewhere there are microphones to ask questions with. Am I right? Yes, I am right. So who would like to start? We've got questions here.
Yes. So thank you for a very
Here's a microphone.
Thank you for a very interesting talk. My question is, healthcare is not just done through hospitals, which have big resources and specialists. So how do you imagine this rolling out in family practice units to the extension beyond AI assistant and some scheduling and organizing methodologies?
Well, again, I go back to how will we know AI is working for us? And if we're talking about being more proactive, having better health, I didn't say anything about a hospital, right? If we're actually motivated to improve health outcomes, that means we have to think about which setting is the best setting for these things to occur. A lot of the proactive nature of AI that can help us needs to happen in the community, needs to happen in family care, and even in other places, doesn't even need to happen in family practice offices. I'm seeing now community organizations having a lot of this technology in their day programming for older adults. So if we focus on our goals of improving health in the health system, the next question should be, what's the best setting for this to exist in? And then we got to get out of the, oh, how do I implement this into the system I have today? It won't work. It won't work. We'll just reinforce the system we have today, unfortunately, or maybe even make just marginal improvements. And I know the other speakers might have opinions as well, so if the other people want to chime in, please do.
Absolutely.
Yeah.
Yep, absolutely. Next question. Over here, I think. Yep.
Thanks for a terrific talk. Not to throw our American colleagues under the bus, but there's very strong entrepreneurial spirit in the U.S., which is good, but sometimes bad. And I just wonder, I was very pleased to hear the emphasis that you and others placed on validation and regulation, but a lot of what we see happening is direct to patient, direct to consumer, that's bypassing physicians and bypassing the regulatory authorities. And I just wondered what your comments were about that.
Yeah, it's a great point. It's a great concern I have. I spend time with our health accelerator at U of T called Creative Destruction Lab, and that's exactly what we see. Really smart, motivated people that are building amazing solutions, but they specifically say we're going direct to consumer because it's too hard in healthcare. And that's the exact opposite of what we want. So somehow we got to work on that culture to make, there was a paper and commentary in CMAJ actually about this week, to make sure that people that work in the system that are entrepreneurs, the definition of entrepreneurship is not making money, actually. It's turned into that. But it's actually about finding creative solutions and being resourceful. And so I would love to see entrepreneurship come and live in our system more. We haven't made it easy, though. And I think that there's some things to do to be able to do that. But the direct-to-consumer stuff it's the Wild West, and it's only growing. And again, now with these AI technologies, I'm worried people are doing pretty much all their primary care now direct to consumer using these technologies, and there's no regulation around it. So there has to be something on that. But I would love to see us shift the culture in health and public health, especially. We do not have an entrepreneurial culture, but to make sure the values of what we're trying to do rest in there.
I think it's a great question that you've raised. I think, and the problem so much isn't the culture, and I say this as someone who's built an AI company and now folding it. There is so much wrong with our culture around risk tolerance, aversion. There is simply not enough there simply aren't enough resources. There's not enough capital. If you look at most of the companies that are funded in Canada, 80% of the funding comes from U.S. investors. Yeah. It's a huge problem, and this ties into data sovereignty and compute sovereignty and all these other problems. So I don't necessarily think there needs to be a culture shift. I know plenty of people who are so focused on the patient and so focused on doing well, but if you don't have runway and you are employing 40 people, which has happened to a company in this area, and you can't make your payroll. Yeah, that's
the culture shift I'm talking about.
Yeah, I agree.
Not the culture shift of the company, the culture shift of the healthcare system of being too risk averse. So that's exactly it.
Fair enough.
Yeah.
I mean, I think it's a good focus. Or it's a good problem for us to tackle upstream in terms of how do we change that. And then part of it, I think, is, as you've already raised, is there's a big regulation policy piece around how do we create enough scale within our country, because we're not a system, we're federated, and I know Dr. Sinclair talks about this a lot. We're highly fragmented, and so a solution that works in Ontario doesn't necessarily work in BC. And so anyway, I violated one of my cardinal rules of commenting and not asking an informed question.
I think it's really valuable to have that perspective. Yeah.
I know we're sitting at the same table, but I didn't pay him for the start. You use the word frequently system, and we don't have one.
Yeah.
It just doesn't exist.
Yeah.
So I would suggest in future talks you just eliminate it entirely.
This is my wish, my optimism.
If you go back to one of your early slides, well, you don't have to, but you have health care on one side and health prevention on the other.
Yeah.
If the overall goal of the exercise is to optimize the health of the population, we can't do it by working on the health care side. We've got to work on the health of the population side.
Absolutely.
And my real question is, how do you foresee AI as changing the culture that allows for a shift from that right side of your slide to, well, let's not say to the left, but to the middle. Because
Yeah,
it's also
yeah.
important that
Yeah.
we reduce the number of darkly shaded squares that are on the right side of the next slide, which showed that we are inevitably, say I, getting older,
Yeah.
and we will
Me
have
too.
things that gotta be fixed.
Yeah, absolutely. I mean, it's such a great question. There's so many pieces to it, and it's literally been what I've thought about my entire career. But the one thing for sure that we have to fix is the incentives in the system. Our whatever we want to call it, collection of health activities is the dissociated pieces. I will use that terminology because that's exactly what it is. It's doing what it's designed to do and where the incentives are, which is to be totally fragmented and not incentivize the system that we want. So at some point, that's got to be tackled. That's a health policy problem, and that's the first one. So that's what I'll talk about. There's other things too, but.
Thanks for your talk. I probably shouldn't have read Atul Gawande's New Yorker article on why doctors hate computers, but it really did explain to me as a family physician why my inbox looks the way it is.
Yeah.
Not to be facetious, I mean, he did go into solutions in the article, great article. So my question to you is, in terms of the pieces around onboarding or socializing or the workflow, right?
Yeah.
So, because ostensibly it seems to me that why do I want all these tests done for me as a family doctor? I'm burnt out. Do I really want more notifications? I gotta check this patient for Hep C, B, A, Z. You understand what I'm saying,
Yeah.
right? So, what would socialization look like? So, what did it look like for you to socialize at Trillium, and or you said you sort of have some commitment or interest in human resource capacity building, right?
Yeah,
So either one of those would be fine.
Yeah.
Thanks.
My answer would be I would ask you to pick your top 5. That's the solution. The people that are working in the system that actually have to use these technologies on a day-to-day basis should identify which are the ones that are going to be most impactful. And it should come, that just hasn't been our practice. We've come with the technology. We think we know the solution. We focus on one part of the problem, and then we try and implement it. So it has to be more embedded. And this actually ties back to the entrepreneurship question. If some of those solutions are actually coming from the system more and more, sorry, I keep using that term, but people working in healthcare or public health, they're much more likely to be useful. So there has to be a lot more thought at that upfront stage. That's what I would say. And by the way, we are talking about that at Trillium. We're trying to engage our clinicians to choose, trying to develop a process for that, and we'll see how it goes. But yeah.
My question, you can't really bake a pie unless you have all the ingredients.
Right.
Can't really run a race unless all the horses are in the gate. I just wondered what your assessment was of the various pieces we need to move forward. Where are we maybe too far ahead, or where especially are we behind?
Yeah, great question. I'm going to have to say data and data infrastructure is the one that we're really behind. And the conundrum we have in Ontario, in Canada, or most health systems around the world, is that it's not funded. Like data and data infrastructure wasn't in the Canada Health Act. We didn't imagine that. So how are we going to resource it and sustain it, I think, is our biggest challenge. The ingredient that I would worry about the most right now.
Thank you very much. As very much a layperson, congratulations, your talk is applicable to many of us, at whether we're healthcare professionals or otherwise. But I follow the news very carefully. I am terrified of the malignant forces that work in the United States currently. And I go, can we make ourselves immune from that? or are we potentially getting sucked into that?
Yeah, very good question. I mean, this is why I was like rooting for the AI for Data Act. Some of that legislation and some of those initiatives exactly were there to protect against these malicious uses of AI, and now we have nothing. So it's a little, I can't tell you that we're protected against it actually right now. We have nothing to protect us aside from our values and, you know, everyone trying to do their best. We need some of those very hard regulations. We need the monitoring and oversight. We need the AI Safety Institute to actually be up and running. But we're at a bit of a vulnerable moment, if I'm being honest.
I think we have time for one last question. Is there one last question around the room? Or maybe, oh, right behind you.
Hi, so I come from computer science, so pretty
Great.
much AI, nothing
Yeah.
about medical science. But I've had the privilege of working with multiple doctors, and I'm very grateful. About the data, you basically ended it with the data. So I'm a data person, and we always struggle to get a hold of the data. Anonymization is a big, big problem. So where do you see, we already have multiple data sources in various places in Canada, right? Brain, you just mentioned some in your talk as well. Is there any plan to bring this data into, I don't think bringing data into one place is a possibility, but linking the data. I know that there were some activities going on, but
Yeah.
what do you think is the future of that?
Yeah, this is, I sigh because you know, there is the Pan-Canadian data strategy now, which is trying to do that exact thing. We fall apart and we stumble two things. One, our provincial, like getting data across provincial borders. And we've been for some reason, it seems like seems like a very solvable problem, but we can't solve it. And the privacy and access piece. I think, though, the demand from patients and community is going to be what tips it over, I think. Because patients are ready and community are ready, expect that we're using this data. And once these benefits start being very tangible and more and more patients are demanding their own data, so that's the force I think that's been missing, let's say, for the last 40, 30 years that we've been trying to do this, that I think is going to change it. But there are a lot of initiatives, but they get marred in politics and barriers and all that stuff.